everybody. Good morning, good afternoon, good evening, good night for all over the world. This is the monthly program of the Wages Center Climate Change Institute of Science and the Indian National Chapter of the ComHAD UK and Lakeside Education Trust. And so, to have a formal invitation for everybody, I request one of the person. He is very well known. He's a graduate from the IIT Madras, and he did the MS in the State University, New York, PhD in Stanford University, USA, and the founder of the Wages Center Climate Change, and also distinguished emeritus professor at this center only. And he was the lead author of the second and fourth International Policy and Climate Change report on this virtue. We have only sixth one we had recently in the November 2021 in Glasgow. And his major scientific contributions were in the area of monsoon models and climate change. Still, he's been continue to do the same thing, and received the Lifetime Achievement Award from the Ministry of Earth Science in 2019. We're proud of him. And as I know, for the past 4.5 years, is a man with certain values, very disciplined man, simplistic way of lifestyle he has, and he has an extending helping hand to everybody with academic zeal to propagate the knowledge between scientist to scientist, scientist to society, society to society. It's a great honor having him here. Sir, we request you to officially inaugurate this program.
Okay, thank you, Dr. Paramesh. On behalf of Professor S.K. Satish, Chairman, DVHR Center for Climate Change, I welcome you all to this monthly seminar series organized by Dr. Paramesh.
Yes, sir. And also, I want to share with you.
And today we're going to hear about oral health. And I request Dr. Paramesh to introduce the speaker.
Okay. Okay. And I want other people who are attending. Srinivasani is also a nephew of the late Sir C.V. Raman, Nobel laureate. So it's a pleasure to have him here. And coming to the subject, today's is on the importance of the oral health for good health. Just to give few introductory remarks on this subject. Among the three systems which have focal point for interaction of the body with the external environment or the respiratory tract, next comes the skin, third comes the oral cavity with the gastrointestinal system. There are nearly 500 to 700 species of germs, starting from protozoa to the viruses, bacteria and all. Most of them gram positive, very less on the gram negative, most of the aerogenic. And oral cavity is bathed from the saliva, which has got secretory IgA, salivary IgA antibody, and a gingival clavicular fluid, which helps to keep the healthy oral environment. 10% of the population suffer from gum diseases, and over 530 million people suffer from dental caries. The gum disease has an impact on the onset and severity of the systemic disease, such as in the pregnancy also, and people who have got oral problems, they're small for dead babies, and prematurity is much high in them. A strong correlation being attributed to the heart attack from the bacteria from the gum. And diabetes, nutrition, other organ indirectly contribute to health-related issue from the oral hygiene. Socialization is also impact because of bad breath and bad teeth. They cannot able to smile. People have to bring back their good smile for everybody and come talk to the near to the people. So I think this conference of scientific knowledge with visionary leadership and social consciousness, even though India recommended this one in 2019, this we have been doing the Indian stuff much earlier than that. Being Appointing me the visiting professor is one of the things linked between so. So there is a lot of gaps. We have to bridge that gap between the science to society, society to science to achieve our goal. This is what we are going to do today. And now to talk about this today's subject,
Huh? Come on.
hello, can we? Hello, hello. Okay, okay. Now we are here to learn more about these issues, and we have a speaker, Dr. Sushi Kadanakupa. She is MDS and PhD, currently working in the Department of Health Dentistry in the Vakkaligara Sangha Dental College and Hospital. She's a consultant on climate change, oral health connection at WHO Southeast Asia. She has received the highest rank in periodontics for the year 2002. Editorial board member of the Science Domain International ADO Journal, Clinical Science in Turkey, and also PTech in India. Her research interest is in climate change oral health, tribal oral health, dental informatics, adolescent oral health, noise pollution in dentistry, tobacco cessation and counseling. She is a columnist for the Prajavani Kannada Daily on social and cultural issues and on women issues and health. She is a columnist for the state news on women and other social issues. She just published a Kannada book that is called Asatyada Kedu, meaning bad impact of the falsehood. If hope I translated Kannada properly. And she has a lot of things to say that it is in brief. We are allowed to have her to talk about it so that we can hear about it. To chair this session, we have another important personality of our city, of our state, our nation, and also internationally. He is none other than Professor Dr. K.S. Nagesh, MDS, and he did BDS, MDS in December 1969. He worked in the Government Dental College, Bangalore, as a faculty from 1976 to 1992. Worked as a founder, professor, and head of the department and principal of the D.A. Pandu Memorial RV Dental College, Bangalore, which is very well known globally. He worked as an advisor in the RV Dental College. He just received the honorary doctorate from Rajiv Gandhi University Health Sciences, Karnataka this year. And also he's a receiver of Kannada Rajyotsava Award in the year 2005. And also Dr. Vensham Gold Medal in 1970 for the best outgoing student. And also he's invited speaker in very international forums in USA, China, WHO, Geneva. We traveled together, and Japan and Australia. And also is a member of the professional bodies, president of Asian Society of Dental and Facial Radiology. And also he's an Indian ambassador Orpheus, European Union for PhD studies. And he's a regional director at International Association of Dento-Maxillofacial Radiology. And he's also a co-author of the textbook also. More than that, he's a founder member of ComHand International. So I think we are proud to have him, sir. And now, before we all starting the handing over to you, sir, let us all clear our time, put the camera on so that we have a picture. This has to go into the bulletin. We request all of you to turn on your camera so that you can have a picture. Okay. Please, all of you, turn on your camera so we'll have a picture. He's taking picture there. Okay. Yes. Yes, I think, thank you. Professor Srinivas, over to you, sir. You take over.
Good afternoon, good morning. Good afternoon, good morning. People from all over the globe are watching this program, and I deem it as an honor for me to be here this afternoon in the prestigious Indian Institute of Science. I would like to thank our good friend Dr. Parmesh for inviting me and saying a few good words about me. Myself and Dr. Parmesh have worked together in WHO and other Rajiv Gandhi University from many years. And I'm sure that the talk with our speaker, Dr. Sushi, is going to highlight the importance of the oral hygiene with regard to the general health is of immense importance in this era of non-communicable diseases, because now the shift has occurred to the non-communicable diseases. I'm sure that we'll have a very good presentation, and at the end of it, we can have the question answers, and I will give my concluding remarks. Once again, thank you very much. Thank you, Dr. Paramesh.
Hello.
Yeah, start, madam.
Yes. Should I share the screen or you'll be sharing from your end? How is it?
If you want to do it, you please go ahead.
Okay,
Yeah, fine. Go
I'll
ahead. Go
start.
ahead. Go ahead.
Okay.
ಅಲ್ಲೇ ಅವರೇ ಮಾಡ್ತಾರಂತೆ ಹೆಲ್ಪ್ ಮಾಡಿ.
Is this slide visible now?
Yes.
Okay. First of all, I would like to thank Dr. Parmesh, who invited me to present a seminar on this day. And I consider this as an honor and my privilege to be doing this in front of all the stalwarts of their own fields. I really feel humbled and I feel really privileged to be doing this with all stalwarts like you. I am very happy to be doing this seminar in front of Dr. Nagesh sir, who is considered to be the highest placed person. We look up to him and is a source of inspiration to all of us in the field of oral health in India. Today,
Can you make it a full screen? Sushi,
Yeah,
can you make it full screen?
yes.
Yeah. Make
This
it a full
is-
screen.
Yes, sir. This is full
Okay.
screen for me, but
Okay.
is it showing full screen for all of you?
No.
Okay. Now?
No, but go ahead. I think we can.
Can you see it now? Full screen?
Not full screen.
Ma'am, maybe you should go to the slideshow and resume slideshow or something.
What is it, sir?
Slideshow at the top. File,
Okay.
home, insert.
Yeah. Slideshow.
From beginning.
Yeah.
Left side from beginning.
Okay. Yeah.
Is it coming?
Yeah. For me, it is appearing full screen.
ನಮಗಿಲ್ಲಲ್ಲಪ್ಪ. Go ahead, madam.
Change slide and see if it moves.
Is the slide moving?
No, not yet. Sometimes this is issues. There might be a lag.
Okay. No, if the visibility is difficult from your end, I don't mind if you share it. However is convenient for everyone. I would.
Yeah, I'll ask him to share it.
Okay. I'll stop sharing from my end.
Yeah. He will do it.
It's okay. When somebody starts presenting, we will have issues.
Okay. Yes. Huh? ಬರ್ತೀವಿ. ಇದರಲ್ಲಿರ್ಬೇಕು.
So
Okay.
the topic of today's seminar is a very important and a significant one, which tries to tell us the importance of oral health for the overall good health. Can you please move the slide? So I would like to take this through to how oral health was conceived by humankind from a historical aspect till today, and how oral health matters, what is the burden of oral diseases, and how it is so important for overall health and well-being of a person. And of course, towards the end, we will also talk about how do we achieve prevention and oral health promotion. Next. When we say good health, the title has very good terminology, that is good health. So whenever we want to define what is health, we always go to the help of the ideal definition given by WHO. In 1948, when it said that health is a state of complete physical, mental, and social well-being, it also said that it is not merely the absence of disease or infirmity. So we know, all of us know, that health is not just the absence of disease or infirmity, but it has multiple dimensions attached to it. And an individual, if he or she is to be healthy, she or he has to fulfill all these multiple dimensions of achieving a good health. And therefore, realizing these multiple complexities attached with health, WHO later clarified further in its 1986 statement that health is not an end in itself, but it is required as a resource for day-to-day life. So it is a resource for everyday life, and it's a positive concept emphasizing social and personal resources. So the physical and emotional well-being of a person and the sociological well-being of a person. So if a person is healthy, he or she can also show that part of being good health or having the sense of well-being even in her or his social and emotional well-being. So it is very important for us to understand the concept of good health from this multiple dimension and not just from a isolated concept or outlook of absence of disease or infirmity. And when we talk about this, when we contextualize oral health in this context of good health, oral health becomes an integral part of achieving this good health. Next slide. So oral health is always considered to be what we call some entity of the oral cavity. It is what we say when we say oral health is, it is not an isolated entity, it is an integral part of general health. And it is very important for us to achieve the emotional part. That is, we are able to express our emotions, we are able to have a sense of confidence and self-esteem, and we are able to socialize with others when oral health is good. So oral health matters in order to complete an individual in all of these aspects. Next slide. So it affects our ability to eat and speak, smile and show our emotions. Next. And these are important for good health. It not even is it necessary for our personal well-being. It is when we think about how it affects our everyday life, like our work, or in case of growing children, when school and learning activities become very integral part of their lifestyle. It even affects school performance and attendance at work or school because of the pain and suffering caused due to oral diseases and disorders. Of course, it affects an individual's self-esteem, especially a growing student's self-esteem is affected by their ability to smile and socialize well as the pain and suffering which they undergo when it hampers their attendance in school. So what does a healthy mouth constitute? So a healthy mouth in this context, please go to the next slide. As Sir was telling earlier, it is not just that a healthy mouth is devoid of microorganisms. It is teemed with microorganisms with more than 700 species of bacteria, fungus, and more. And they are all arranged in the form of an oral biofilm, that what we call dental plaque. And this oral biofilm finds its place in different parts of the oral cavity. Biofilm not only adheres only on the hard tissues, that is the teeth, it also adheres on the tongue. It is very prominently present between the area between the teeth and the gums, that is in the gingival clavicular area. And that is why healthy mouth should be distinguished that it is not a cavity which is devoid of organisms, but most of these organisms are not harmful. And this is a combination of this. It's a microbiota of which exists in symbiosis, and many of the good oral microorganisms, they help in keeping the balance and keeping the symbiosis in a balanced way. That is, the harmful bacteria and the harmful microorganisms present or checked with the help of good bacteria. Next. And of course, when there is oral dysbiosis, when we see the fluctuation in the fine balance in the oral microbiota, which results in dysbiosis, it can lead to a range of diseases and conditions. It may include, as we all know, tooth decay, that is, we call dental caries, gum diseases, they are called periodontal diseases, which can result in tooth loss. Oral cancer is one of the most dangerous oral conditions. Oral manifestations of HIV infections, orodental trauma, and noma, which is what is called cancrum oris, which is highly neglected gangrenous condition of the oral cavity. birth defects such as cleft lip and cleft palate. So all of these various disease conditions will constitute to what we call oral diseases and disorders. Next slide. So when we think how this common oral diseases like dental caries or periodontal diseases and other oral conditions came about, we saw the first evidence, historical evidence and the ecological evidence of oral diseases through bioanthropological researchers. And next slide. This shows that the earliest evidence of oral diseases was found in the hominid species as early as 1.3 million years before present. So that was found in the paleopathological record of ATE 91 jaw, which was excavated in Spain in Cima del Elefante site. So that earliest evidence showed that the jaw of this species, hominid species, showed many maxillary oral lesions. The maxillary is the upper jaw. Lesions in the upper jaw showed hypercementosis, that is thickening of the cementum in the root surface of the tooth, calculus deposits, periodontal disease, cystic lesions, and an anomalous wear facet compatible with tooth picking. But we did not show any evidence of caries because it was way before the invention of agriculture. Next slide. And when we saw caries is very interesting because the unquestionable oldest evidence of caries comes from a fossil found in 1921 when there was an exploration of the zinc mine which was conducted in the northern Rhodesia in Zambia. So that was the first found oldest evidence of caries. It belonged to a Homo rhodensis cranium, which was around 650,000 to 160,000 million years before present. It showed extensive dental caries and coronal destruction. And this first evidence of dental caries, that is tooth decay, which was found in a skull way before the invention of agriculture by mankind, led to the concept of what we call the carbohydrates, which were present even before cooking became an invention. So it could be due to through the plant sources and fruits and some forms of nuts, which could also have resulted in caries. But the caries incidence increased periodically with the advent of agricultural era because humankind shifted to carbohydrate-rich diet, plant sources, because once we invented cultivation of crops, it was unlike the hunter-gatherer lifestyle diet, which was mainly consisting of meat and protein. So as we progressed further, that is after the invention of agricultural era around 10,000 years ago, we have been seeing the anthropological evidence of the prevalence of dental caries in the human population. Next slide. So this, at present, now we see that oral diseases, including the most common dental decay, is the most common diseases of humankind. Almost all human beings will experience one or the other oral disease. It's commonly present. Next. So let us see what is the burden of oral disease now on the human population. Next. So when we refer to this recent study on global burden of diseases, which was done in 2017, oral disease was found to affect 3.5 billion people worldwide, and oral cancer is among the top 15 most common cancers worldwide. Next. Dental caries, as Sir was telling before, 2.3 billion people suffer from dental caries in permanent teeth, whereas children in their primary teeth, also called deciduous teeth, in their milk teeth, around 530 million children suffer from dental caries. And the untreated dental caries in permanent teeth is the most common health condition, which is causing the burden of diseases in the tooth, as we found in the study conducted in 2017. It causes pain or suffering. Next slide, please. It also results in loss of school hours among children. So dental caries among children acts in multiple dimensions to affect the overall well-being and health of a child. So especially very interestingly, what we are finding is the impact of dental caries on the learning period in the growth and development of the child. So the loss of school hours, it is estimated that annually around 34 million school hours are lost among the child population, among the children population, because of the dental caries and because of the unplanned dental visits which happen. So the child has to miss going to school because of the pain and because of the unplanned dental visit. And as we all know, dental visits does not take just half an hour or 40, at minimum it takes around half an hour to 45 minutes, and it requires multiple appointments. And this also, the suffering the child goes through has also affected school performance. So many of the studies have recently and consistently have shown the impact of dental caries on these two parameters. Next. We also in our department conducted a study to know how the material deprivation, that is poverty and school absenteeism, can be used as indicators of dental caries experience among 12-year-old school children. When we did this study in 2016, what we did was we used the UNDP multidimensional poverty index, which is a very interesting index, and it uses all the multiple dimensions of the poverty. We use this index to assess the poverty levels in the households of these children attending schools. And what we found was, next slide, was that around 120 school days were missed among these children because of dental reasons. And the dental caries experience of this study's participants, that shows that at least 2.31 plus or minus 1.33 was the prevalence of dental caries in this children. So among all the school days missed, even the dental reasons due to dental diseases, dental reasons, either visits to dentist or due to caries, pain and swelling caused due to dental diseases, the children reported a mean loss of 120 days in a year. So there was a significantly positive correlation which was found between caries experience and poor households. And we could show that caries experience and school absenteeism, they act as mediating factors as well. So it has a significant impact on the overall well-being of an individual. Next slide. When it comes to periodontal diseases, we know that severe periodontal diseases, that is gum disease, when it extends onto the periodontal ligament, is very common. Almost 10% of the global population suffers from periodontal disease. Next. This is, as we all know, is caused by the poor oral hygiene, the biofilm, the oral biofilm, which causes which is actually the common factor. The dental plaque is a common etiological factor for both of these diseases, that is periodontal disease and dental caries. And another very important cause of burden of oral diseases is oral cancer. One of the three most common cancers in most of the countries in Asia and the Pacific is oral cancer. And it is more common in men and more common in older people, and it strongly varies by socioeconomic condition. And of course, it is very much related to tobacco and different products, tobacco usage product among the individual, which is also most commonly seen in men, but it depends upon what type of product we use. The chewable form of tobacco is commonly seen in both these sexes in that way. Next. Another important aspect of oral health is the trauma which is caused to oral and dental tissues. Around 20% of people suffer from trauma to teeth at some point in their life. So it is not only just the hard tissue, but at the same time, the paraoral structures which gets injured during the orodental trauma. Next. And NOMA is also one of the oral diseases, which is a severe gangrenous disease of the mouth and the face. And unfortunately, this is the most neglected and almost forgotten disease because it is found only in extreme poverty. It's not usually seen, but seen in extreme poverty, which the poverty acts as a root cause for poor hygiene and sanitation, where we also see poor oral hygiene. And reduced immune system. So that there is already the compromised immune system in the children, especially it is seen in the children in the age group of 2 and 6 years of age. It has a very high mortality rate, almost up to 90%, and very poor prognosis. So this is a highly neglected issue and found mostly in the Southeast Asian and African regions, and it is a strong indicator of extreme poverty in any society. Next. HIV is a major, we know it's a major disease which inflicts on the quality of life of an individual. Many times, HIV presents its first manifestation in the oral cavity. 30 to 80% of HIV positive individuals have oral manifestations. And most commonly, what we see is the oral candidiasis. We do see fungal, bacterial, and viral infections, but the most common first symptom, usually the dentist might become the first healthcare professionals to diagnose HIV in a patient through the appearance of oral candidiasis. It causes pain, discomfort, dry mouth, and difficulty in swallowing, and it is shown to very significantly reduce the quality of life of an individual. And especially it is more common among those who cannot afford the ART as well. Next. Cleft lip and palate are also one of the disorders which impairs the quality of life if not detected early and treated. It is common, it is present in more than 1 in 1,000 newborns worldwide. And of course, genetic predisposition is a major cause, but even then, poor maternal nutrition, tobacco consumption, alcohol, and obesity during pregnancy also play a role in cleft lip and palate. So complete rehabilitation is definitely possible through surgery with very early detection. Next. So when we look at the burden starting from early age during childhood to the adulthood, we see that there is a definitive link between oral health and systemic health. And there is a bidirectional link. They both are bidirectionally related with each other. Next slide. What we see here is that we use the terminology what is called oral systemic health. When we say oral systemic health, we are indicating that oral cavity is a mirror of systemic health, because many systemic diseases also have oral manifestations. At the same time, oral diseases per se will impair the patient's nutrition and well-being because of the tooth loss, avoidance of certain kinds of food if we have pain and discomfort, or reduced masticatory ability because of the tooth loss. All that is impairing on patient's nutrition and well-being. Of course, the inflammation in the gums, especially the periodontal disease, results in a lot of dysbiosis in the rest of the body as well, which we will see in the next slides. It reduces quality of life, and also it is a great source of stress and anxiety in the people. Next. So this is when we come to this concept of non-communicable diseases. Oral diseases are clubbed under the broader umbrella of non-communicable diseases. And it is so true because oral diseases share a lot of common risk factors for non-communicable diseases. This is the uniqueness of oral disease. Oral diseases share risk factors with non-communicable diseases. And this is also a realization which helps us to address our preventive measures as well. Next. So what are the common risk factors? The risk factors are tobacco use, betel areca nut chewing, alcohol consumption, unhealthy diets, high in free sugars. All of these are common risk factors for the leading non-communicable diseases, which are cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes. And oral diseases share the same common risk factors. Next. Here, what we need to focus on is the oral microbiome. How oral microbiome responds to these common risk factors, and in turn with the other underlying comorbidities. So the oral microorganisms have the ability to spread to distant body tissues via blood vessels of the oral cavity or via the gastrointestinal tract. It reaches different organs, produces distant local dysbiosis. So, for example, if you look at the correlation between oral microbiome impairments and an increased risk of pancreatic and liver diseases, we have seen. That is because we have been able to identify, locate predominantly P. gingivitis microorganism in these tissues. So it is possible that oral dysbiosis, the fluctuation in the balance of the microorganisms in the oral cavity, can reach to distant organs. Next, therefore, oral infections, the oral diseases, have to be checked. And the bidirectional link is especially seen very obviously in case of diabetes and periodontitis. So the infection, severe infection of the gums, which leads to periodontitis, has a bidirectional link with diabetes. So what we see is the periodontitis, that is inflammation of the gum, results in oral dysbiosis, which results in chronic inflammation in the human body. So periodontitis is a chronic inflammation of the gums. So it is present for a very long period of time, all the time. So it is a chronic inflammation in the body, which correlates with peculiar inflammatory and vascular patterns. And this, what happens is, it cuts across all the older age group and all those people who have risk factors such as tobacco and alcohol consumption. It is gets accentuated, and this is the case because it can result in what is called inflammation getting to distant organ system through the gastrointestinal system or through bacteremia, that is through the blood vessels as well. Next. So in the long term, what happens is the inflammation present for a long term in the oral cavity can result in causing an imbalance in the pro-inflammatory and anti-inflammatory gene responses. So we do see polymorphisms of the interleukin-10 gene, as well as we see the polymorphisms of tumor necrosis factor alpha, interleukin-1 alpha beta RN, collagen type 1 alpha, as well as the vitamin D receptor gene. So all of these get altered in because of the periodontitis. Next, this results in increased risk of cardiovascular disease and respiratory mortality. So periodontal disease, long-standing periodontal inflammation, particularly bacteria from the mouth, can be an increased risk for CVD because of the circulation to other parts of the body. So periodontal disease and dental caries, both the conditions are associated with increased risk because they are associated with dental biofilm of the infected teeth. So that means inflammatory markers are always present. If oral hygiene is not maintained well, it is linked with pneumonia, it is linked with increased risk for cardiovascular disease. Next. So therefore, the strategies to prevent and treat periodontitis goes hand to hand with the management of other lifestyle diseases, that is the non-communicable diseases. So it should always be multifactorial, it should always be multidisciplinary, both in the personalized medicine, taking in the view of the holistic approach. For example, when we propose physical exercise along with nutritional counseling, it is important and used for the management of type 2 diabetes. But it is not only helping type 2 diabetes, but it is also reducing the prevalence of cardiovascular risk as well as periodontitis. So this bidirectional link helps in common risk factor approach, which can be very efficiently used not only by oral health professionals, but can also be incorporated in the primary health care with all the other healthcare professionals as well. Next. When we come to cancer therapy, how does cancer therapies impact the oral health? Is that when we use chemotherapy or head and neck radiation therapy or thyroid cancer radioiodine therapy, they all potentially damage the dental tissues, and ultimately they are altering the oral microbiome in the oral cavity. So again, it causes dysbiosis. And next, therefore, we need to involve different approaches to when the individual is going through these cancer therapies. We can play a lot of focus, pay a lot of focus on oral hygiene procedures. We can also use other approaches like using prebiotics and probiotics, host response modulators, and using nano-sized drug delivery systems. Next. And all of these oral conditions, whether it is periodontitis and caries, or patients with oral and potentially malignant disorders or oral cancer, they all have functional, social, and psychological impact on the individual. So it reduces the quality of life of the patients suffering from these diseases. So oral health related quality of life is a very important aspect to be considered when we consider the overall health of an individual. Next. We also see this bidirectional link with some of the systemic diseases. So most commonly what happens is the quality of life gets deteriorated in specific systemic conditions which affect the oral hygiene. So if the patient has condition like hemophilia, it is very difficult to maintain oral hygiene because of the tendency to bleed. So if you just brush using even a soft bristle toothbrush, the patient will very difficult to maintain oral hygiene. So the systemic condition in turn is affecting the maintenance of oral hygiene. Similarly, in patients experiencing oral complications of particular drugs, including medication-related osteonecrosis of the jaw, there also the oral hygiene gets deteriorated. Anti-resorptive drugs, which are used for the treatment of these diseases, will also result in reduced quality of life in such individuals. Next. When we look at this microscopic level, a clinical aspect of how oral health impacts on the general health of an individual, we cannot avoid looking at the oral health inequalities, which takes us to have a macroscopic outlook towards this disease, that is oral diseases. So oral diseases need also to be understood from a public health point of view, because the inequalities what we see in the oral diseases among the population is the biggest roadblock to achieve good health among the people. So it is very important to recognize that all this burden of oral diseases, of what we see, the pain, suffering, and the loss of school hours or the loss of productive hours during the work, or the reduced quality of life due to different systemic diseases and the bidirectional link between them, they all disproportionately affect the poor and socioeconomically disadvantaged communities of the society. And they oral health for good health. Next. So the socioeconomic status is the one very important factor or a variable which decides the prevalence and severity of oral diseases. So it just cuts across the entire life course of an individual, starting from early childhood to older age, across the populations in high, middle, and low income countries. So just to illustrate this point, next slide, please. I would like to share the study which I did as a part of my doctoral thesis, where we studied what we saw across the life course of an individual when adolescent children moved in their socioeconomic strata. So the socioeconomic mobility, and is it related with oral health? So if an adolescent is born, this study concentrated on adolescents. It was a longitudinal study with a retrospective aspect to it. So we had a retrospective aspect in collecting information from birth to adolescence, and from adolescents, that is from 11 years, we did a longitudinal study of a cohort of 11-year-old. So we followed them up for 5 years. So what we were interested to see was, if a child is born in a low socioeconomic family, and during the course of its life, till 11 years, and after 11 years till it became 15-year-old, did the family of that child move from low socioeconomic status to higher socioeconomic status, and vice versa? If a child was born in a high socioeconomic status family, during the course, did it mobilized downwards, that is to a lower socioeconomic strata? And if a child which is born in a low socioeconomic strata stayed in the low socioeconomic strata even across its life course till it became 15-year-old. So next slide. When we saw and hypothesized on these social mobility theories. That is, we concentrated on the social origins theory, that is, a child is born in a low socioeconomic status, stays there, or a child which saw the upward mobility, low to high, downward mobility, born in high socioeconomic society, but it moved to low socioeconomic strata. In all of these, what we observed was we took the oral diseases in terms of dental caries. We took the CPI course, that is Community Periodontal Index. For bleeding and calculus and oral hygiene scores also we had recorded, as well as the traumatic dental injuries. So all the major chronic oral diseases were assessed with respect to these hypothesis of the socioeconomic mobility. In all of this, next slide, what we saw was a significant increase in the mean dental caries in the adolescents who were born in low SES and moved to high SES, and adolescents who were born in low SES and stayed low at SES at 15 years. They showed a significant increase in dental caries, mean bleeding, and traumatic dental injuries. So the risk-taking behavior was more among lower socioeconomic adolescents. So all of this was indicating towards the impact of socioeconomic status on the oral health and its impact on the overall well-being of an individual. Next. That is one aspect, that is the socioeconomic status. The second important aspect of inequality in oral health, which we see in our communities, is the access to oral health services. When we see the access, we see the unequal distribution of oral health professionals. WHO says we should have dentist to population ratio of 1:7,500. But in India, we see 1:10,000, but that too only in the urban populations like in cities. But if you go to villages, and we know that 70% of the population in India live still in villages, we see the ratio expanding so big, that is 1:25 lakh is the dentist population ratio. So when the oral health professionals are unequally distributed, the access to oral health services becomes extremely difficult, especially for those who are at the lower socioeconomic strata. Next. The other important aspect is the affordability also. Before we go to affordability, the low access to primary oral health services was assessed during a World Health Survey which was conducted in 2012. It shows interesting results. It shows that 35% in low-income countries they have less access to primary oral health services. And that too, it assessed only primary oral health services, not specific curative services. In lower middle income countries, 60% have low access. In upper middle income countries, 75%, and high income countries, 82% have access. So we see that the access is only 35% in low income countries, whereas 82% in high income countries. So the accessibility is really a big hurdle, which even in India we are facing. Next. Along with accessibility, it is the affordability. We know dental treatments are costly, and it amounts to almost 5% of the total health expenditure. And also it amounts to 20% of the out-of-pocket health expenditure. So it's extremely costly, and not all families can afford to go for dental treatment. Next. Therefore, prevention becomes our mainstay, especially true for oral diseases, because it is most cost effective for us to prevent. And we can do this by two approaches. One is at an individual level, at a clinical setting. Another is at a community level, which will look into all those factors which are beyond the control of an individual. Next. When we look at individual oral health promotion, we really are dependent on behavioral approach. That is, in clinical prevention, we may achieve optimum oral health of an individual when they come with oral diseases. We may treat them. So we are basically using a curative approach. Whatever the dental treatments are required, we do. At the same time, in the clinical setup, we can also do some amount of prevention using health education. So health education, we all know that these three things: brushing twice a day, using soft bristle toothbrush, using dental floss to remove interproximal dental plaque, and tongue cleaning, because oral biofilm or dental plaque, we know that it does not just accumulate on oral heart tissue, but it finds its place more so even on the tongue. So it's very important to clean the tongue as well. But these are all highly dependent on the behavioral health behavior of an individual. So it requires a lot of effort from the individual. So it requires a lot of empowerment. So empowering the individual to take care of his or her own oral health should be done ways. So a dental patient should first be looked at not just as a dental patient, but as an overall individual with all the components, social, economical, psychological or psychosocial aspects attached with their, which could be influencing their health behavior. So that is why many techniques of improving the the effectiveness of health education in clinical setup have been explored, such as motivational interviewing, counseling, and models-based interventions, etc. Among them, of course, the motivational interviewing has shown to be more effective than the other techniques, but these are the things which are available for us in a clinical setting. That is on a one-to-one approach, what a clinical dentist can do to improve oral health. That is to prevent further incidence of oral disease in a patient. But even in a clinical setup, an individual dentist should have an overall approach. That is a comprehensive approach of looking at an individual as a whole, not just as a mouth, but as a whole individual. And only then the preventive approach in a clinical setup can become effective, because we should remember it is highly dependent on the next slide. And it is true that looking at the vastness of oral diseases, because almost everyone in the human population will have one or the other oral diseases in at least at any point in their life course. It is impossible for us to have individual level approaches to achieve good health through oral health. We have to go for community level prevention using public health interventions, because many of the variables what we discussed, which are the root cause for oral health inequalities, such as the socioeconomic status, the accessibility and affordability of these services, and even the affordability and accessibility to um, as simple as buying a toothbrush and toothpaste can be difficult for uh, individuals. It's not easily accessible to all of them, because toothpaste, if you want to buy a toothpaste now, it comes under 18% GST. So it's not easy for a poor household to buy a soft bristle toothbrush for each individual members of the family. Because when we go for school oral health programs regularly, when I visit all these outreach programs and interact and be with them, what I see is, and what the vast amount of literature also shows, is that achieving oral health is extremely difficult for the underprivileged sections of the society because of the inequalities. So it goes beyond the control of the individual. So even if we create awareness among them, okay, now our department has adopted 6 schools. We go and we do oral health awareness campaigns, we do treatments, we educate them. Now they are all aware, they know how to take care of their oral health, they know, they have the knowledge, they are aware. But can they implement it? Because they need access to it. That's why when we remember the WHO's expanded definition given in 1986, health is a resource for everyday life. So we need to also have the affordability and accessibility to have certain resources which can achieve oral health as well. So there are many factors which go beyond the control of an individual, and an individual's health is always influenced by many social determinants. So the social determinants of health also act on oral health. So we do also have social determinants of oral health. That is when we need public health interventions at a macroscopic level, that is community. That is when we talk about community level prevention. Next. And this is where this particular approach, which was first given by Aubrey Shaham and Richard Watt in the year 2000, becomes very helpful. So it becomes helpful both in the, especially in the primary healthcare setup. When we are talking about integrating oral health in the primary healthcare setting, so that we integrate the oral health into the general health care services in the delivery level itself. When we integrate oral health, this approach becomes very, very useful, because according to this approach, it shows that along with obesity, heart disease, diabetes, all of these non-communicable diseases, even oral diseases such as dental caries, periodontal disease, traumatic dental injuries, they share the common risk factors such as smoking, alcohol, insufficient exercise, stress, lack of control over life events, diet high in sugars, fats, and salts, all of these, which are common risk factors for both oral diseases and non-communicable approaches. So this approach is very much important to understand the social determinants of oral health as well, and gives us a very important tool in formulating public health interventions to prevent oral diseases. So such interventions are, next slide, mostly based on common risk factor approach. So the interventions which are proposed by World Health Organization to prevent oral diseases are, the first one is promoting a well-balanced diet. A well-balanced diet, especially very important, is it should be low in free sugars and it should be high in fruits and vegetables. So low in free sugars not only tackles oral diseases, it also tackles major non-communicable diseases. And now non-communicable diseases are not only present only in developed countries, they are seen more commonly even in developing countries or low middle income countries like India. India especially now is facing with a double burden of having both infectious diseases as well as non-communicable diseases among all the socio-economic strata. So it is like, because of the re-emergence and resurgence of infectious diseases which is happening in the 21st century because of various reasons like antibiotic resistance, climate change, and other things, we are having a resurgence of infectious diseases. The infectious diseases and microorganisms are coming up with more vengeance now with new infectious diseases. At the same time, we are also having non-communicable diseases. So very important factor to tackle this is the diet, which has to be low in free sugars. And that is what is required to prevent oral diseases as well. So if you remember, if you go back the anthropological evidences, what it showed was the earliest evidence of oral diseases, which was found around 650,000 calibrated years before present, showed no evidence of caries, but it showed all the other oral diseases. But only during the around 10,000 years back, that is during the agricultural era, when we shifted to carbohydrate plant based rich food, we started having carbohydrates and of course also non-communicable and lifestyle related diseases. So it is this very important aspect, the first important proposal by WHO to tackle as a public health intervention, is to promote a well-balanced diet in free sugars, low in free sugars and high in fruits and vegetables, and also very importantly favoring water as the main drink, not the flavored water drinks. And we have lots of the advertisements which are very tempting for especially the younger population to go for the many liquids which are highly carbonated liquids with high sugar content in it. So all of the packed food, any packed food for that matter, has free sugar in it. So what the nutritionists say is, please take any natural food which does not have ingredients printed on it. So if you take an apple, it does not have ingredients printed on it. If you are holding something in your hand where you can read the ingredients, please don't eat it, because it has to come from natural sources and it should be good in proteins and fibers and minerals, which is good for even oral health. And water is the best source to cleanse our mouth, reduce the pH, and rehydrate the body and even the saliva and oral cavity. Next. And the other important public health measure, as we all know now, we have enough evidence to show. We don't need any more study to prove that tobacco is linked with lung cancer or oral cancer. We have enough evidence, but the only unfortunately we have not been successful in bringing an effective policy to eradicate tobacco from any societies in the world. So stopping the use of all forms of tobacco, including chewing of areca nuts, is another very important uh, public health recommendation given by WHO. Next. Reducing alcohol consumption also is another important aspect of, for prevention of oral health, because alcohol, along with tobacco, has a modifying effect on the oral soft tissues, especially. Next. Also, we have to encourage, we should keep in mind that more than 20% of the world population at any one point is at a high risk of orodental trauma. So whenever we, especially children or people who play sports, should wear protective equipment like mouth guards. And people, when they are traveling on bicycles and motorcycles, also should wear protective equipment to reduce the risk of facial injuries. And even the school play areas, there are a lot of recommendations how to prevent, at least how to reduce the impact of accidents which happen during school. So the playground areas, how to build the playground areas in the school to reduce the injury to the orodental trauma. All of this, the literature is available, and some of the countries, like in the Nordic countries have or have already implemented such safe playgrounds, school grounds. Next. And of course, it's a global problem. Oral health is a global problem because all the people, they suffer from global disease, and the burden of global diseases is significant. So definitely it needs a global response, but we saw the global response very late. So for the first time in 2011, we saw that United Nations high-level meeting on non-communicable diseases, at least it recognized that oral diseases pose a major health burden for many countries. So that was the first recognition that we got, that it is also one of the major non-communicable diseases, which is posing a major public health problem. But it is only after 8 years after recognizing it, after it took 8 years, so it only in 2019 it was included. So there was inclusion of oral health in the political declaration on universal health coverage. So officially it was included in the political declaration on universal health coverage. So oral health is included in the universal health coverage, at least in the political declaration on universal health coverage by the United Nations in 2019. And at the same meeting, it proposed for a 3-year roadmap to develop a global oral health report. Next. And also, what we saw was a historical resolution last year. It was on oral health for the first time, 74th WHO World Health Assembly had a historical resolution on oral health, that it included oral health in the prevention and control of non-communicable diseases. Next. So it addressed, so the 74th World Health Assembly last year, it resolved that the member countries to address the key risk factors of oral diseases, and it addressed and stressed the point to enhance the capacities of oral health professionals, and it also encouraged the preventive approaches rather than curative approach. So it recommends to shift from traditional curative approach. The biomedical approach is very limited and cannot be depended upon to achieve good health. Therefore, the promotion of oral health within families, schools, and workplaces can happen only through preventive approach. So next. So it is very important that oral health also needs to be included in primary healthcare. And also last year, what we saw was, for the first time in the history of oral health profession, we saw that 3 dental preparations were included on the WHO model list of essential medicines. These were the fluoride toothpaste, 1000 to 1500 ppm fluoride containing toothpaste, glass ionomer cement, and silver diamine fluoride. Silver diamine fluoride is also highly cost effective. It's very affordable, easy to apply, and it arrests the caries lesions. So that is also nowadays highly explored as a preventive measure. So these three dental preparations now come under the essential list of essential medicines, list of essential medicines. So that's a great achievement of the oral health community across the globe to make this happen. Next. So the contributions to coming to the end of what I wanted to discuss with you all is that with all these challenges the oral health community is facing with to achieve good health of an individual is the one of the significant challenges of the 21st century is the climate change, because even the climate change has oral health concerns because it impacts on the operations and effectiveness of oral health services. And as we know very realistically and on a first-hand basis, we all have realized how during COVID-19 pandemics, the oral health services were severely hampered to people who really needed oral health services. So it has caused a lot of challenges in achieving oral health and through that good health of the individuals. And therefore, it is a high time now at least to consider oral health as an integral part of general health in all of our in our endeavors. It is to realize that oral health cannot be looked as an isolated entity, and it has a great impact on improving the quality of life, as well as especially in the lower socioeconomic strata, it also impacts on the good growth and development of children if they are prevented from pain and suffering caused due to dental caries, orodental trauma, and especially the loss of school hours and the improvement of the school performance, which can be achieved through oral health promotion. Next. Complete my presentation. These are the references. You can run through these slides.
Yeah.
Thank you everyone for giving me this opportunity to share my thoughts. Thank you.
Thank you, Dr. Sushi, for an extensive coverage on the various aspects of the oral diseases and its impact on the general diseases, and also what is the burden on the society, the family, and the individual. Now, any questions, sir? I can.
Yeah, Madhu is here.
Can I ask a question, sir?
Madhu is here. No. Anybody else?
Madam, you mentioned that radiotherapy can cause oral cancer and other things. What about the drugs which can also cause this oral health disease? Like gingivitis, that is. Some of the drugs which is used against the epilepsy can also cause
It's not
this
clear.
gingivitis.
Can you be a little more clear? It's echoing. The sound is echoing. I'm not able to hear properly.
Yes.
Sure. See, apart from whatever she has mentioned, sir, you raise a very important question about the drugs that is being used, and it has got a oral manifestations, what we call as iatrogenic diseases or the drug-induced diseases. It may be antihypertensives like nifedipine. It may be anti-epileptics. Then various drugs used in treatment of Parkinsonism, drugs used in psychiatric illnesses like common antidepressants. All of them will cause oral manifestations in the form of gingival enlargement, or in the form of dryness of the mouth, which interferes with the swallowing, which interferes with the speech, and also they find it difficult when they go for public talking or anything like that on these drugs. They experience extreme degree of xerostomia, and that is really one of the challenges that we are facing as dental surgeons, especially in the field of oral medicine. So it needs to be, because in such a situation, we cannot give up life-saving drugs like anti-epileptics or antihypertensives. So somewhere we have to find a pathway where we can take good care of the oral health, so that we will be able to maintain both the good oral hygiene as well as continue with whatever the medication the patient is taking. Madam, other things, if there are no other questions, I want to make some observations. Can I? Yeah. Yeah,
Sir, I
Madam,
have a question. Can I
about
ask one?
fluoridation of the
Yes,
water.
ma'am.
Here we have to be very cautious, because we cannot apply it as a general rule, because in our country itself, there are certain areas where the fluoride content is very high in the drinking water. As such, people are suffering from fluorosis, which is again causing a lot of medical problems in the form of dental fluorosis, in the form of skeletal fluorosis, and also social problems in some villages where the fluoride content is very high. Because their teeth are yellow, they don't want to get married from that village, either the boy or the girl. So we have to be, defluoridation is as important as fluoridation. And also when we are using the fluoridated toothpaste, we have to be very cautious in addressing the children or instructing the children not to swallow the paste. So that's one very important one. And many of the genetic disorders also have a role to play. For example, there's one condition. Yeah.
What is the quantity of paste we have to use?
Yeah, you see, normally we say that you spread the entire the toothbrush, whatever the length of the brush. Okay.
And how many minutes you have to brush it?
At least about 5 minutes we have to, because all the directions we have to brush and then see that. So, for example, genetic diseases are now taking a very upper hand. When we were studying medicine, I am sure Dr. Parmeshwar also will agree, genetics was a chapter in medicine, but now medicine has become a chapter in genetics. So we have to see that many of the genetic disorders have profound oral manifestation. For example, a condition called as osteogenesis imperfecta, where the bone is very brittle, and it manifests first as a dentinogenesis imperfecta, where we see discoloration of the teeth, and we could play a very important role. And the other thing is, saliva is going to be one of the important marker in diseases. We have made an attempt along with Dr. Gundu Rao from the Minnesota University to develop a non-invasive glucometer by using estimation of the glucose in the saliva. And if that is taken up as a big project and then at different multi-center studies done, if we can develop a non-invasive glucometer, that will be a very big boon in patients with diabetes. And also, we are also found in one of the studies in Brazil, that is the first molar tooth, the permanent tooth on the occlusal surface or the biting surface, you find a saucer-shaped depression in patients who are with diabetes mellitus. So early saucer-shaped depressions on the molar teeth could be a precursor to predict that person is going to have a diabetes at a later stage. To explain this further, it has been found that the enamel, which is the hardest substance in the body, harder than the bone, and the islets of Langerhans cells of pancreas, they develop at the same time embryologically, and any changes or adverse effect at that time could bring a change in the enamel, because the tooth erupts first and the enamel is the one which shows the changes in this diabetes patient. Of course, this needs further studies and multi-center thing. Other area which is of a great importance in the coming year, is forensic odontology. We as the dentists or oral physicians, we play a very important role in assessing the age, sex, identification of the dead persons, especially when there's a mass disaster. In fact, Hitler was identified by his tooth treatment. And in 1992, there was an air crash in Bangalore, and I was called to be one of the witnesses or the expert to prepare a dental chart. And this is another area where we need to have definitely a focus to play. And as you said, oral disease is a top in the non-communicable diseases like oral cancer, which causes a huge burden on the family, both psychologically as well as financially. Then now we have come across this COVID-19. In the second phase of the COVID-19, we came across the mucormycosis or black fungus, which has hit a large number. In one of the studies, data collected other day, as many as about 90,000 patients are affected, reported all over the country. That may be because of the injudicious use of the steroid or whatever may be the reason. Because steroid was to be used at that time to save a life, but there is the effect that we see where we see the necrosis of the maxilla and loss of all the teeth, and the entire maxilla has been removed. Now the rehabilitation is a big challenge because we have to give them a denture or we have to give for an implant, which is going to be very expensive. And we have to see that we don't know what is the post-COVID effect in the coming years unless nobody knows whether it is the dentists or the physicians or surgeons. So we have to wait for next 6 months, 8 months, what would be the effect in the oral cavity, what would be the effect in other parts of the body, and why it resulted, how we can manage. And this is going to be a big challenge to the medical professionals. Madam, you have extensively covered on the need to develop a school health program. We have been always advocating that we had to have a checkup, school health checkup, wherein even the oral health checkup should be made mandatory, because nowadays most of the schools, elite schools, of course, they have the program, but the government schools have to draw a definite program of general health checkup and oral health checkup, and also arrange for the simple talks and simple procedures at the school level. That will go a long way because 40% of our population are in the younger age group. And the other one that is taking up is the senior citizens or older population, because of the life expectancy being improved, increased, and the medical technology and the life-saving methods have increased. We have found a large percentage of senior citizens who also need oral attention in the form of dentures, their old age related issues. These need to be addressed in the coming years. And of course, now the medical field, we are coming across artificial intelligence. There may be a room for to use artificial intelligence also in the coming decades, and a vast scope of research, vast scope of intervention is required at the governmental level, individual level, non-governmental organizations, both in the urban and rural areas, both in the developing countries and developed countries, because each one of them are facing different problems, oral health issues, and relation with the general health issues. So this needs to be addressed by all of us sitting together. What is good for India may not be good for other countries. What is good in those countries may not be good. It varies from country to country, region to region. In a vast country like ours, which has diversities in cultural, religious, food habits, socio-economic conditions. So all this has to be taken into consideration. I'm sure that you being one of the leading lights and other ones for the younger generation of our dental surgeons have to take this further forward for the better living conditions. So let us create smiles on the face of the children and the population. Thank you very much.
Thank you, sir. That's very true.
Yeah, if there are no questions,
I'm sorry, this is Prachi. I don't know if you guys can hear me.
Yes, I can hear you.
Okay, I posted some questions in the chat session, but I don't know if anybody can see them or not.
please.
Okay. Haven't seen them.
So there is one question from the audience.
Okay.
With the building of better infrastructure in India with faster speeds of automobiles on the road, is there an initiative directed towards public education on safety related to seat belt and mandates? This is necessary not only for limiting oral injuries, but saving lives in general. So, Dr. Shushi, would you like to answer this? Please take this.
Yeah. So, well, as far as I know, of course, the safety, road safety, and the rules, as the there's a ministry of the ministry from the central government itself has made many policies regarding it, and we do have regulations on all of this. But as you have raised, public education on safety has not reached the mainstream media as such. So we don't see that a kind of public awareness initiatives being taken up and reaching the grassroots levels of communities in the society. So, of course, that is again a common risk factor approach. If you have such initiatives on a public intervention level, it will address both oral injuries as well as the injuries to the rest of the body as well. So that is a very good awareness campaigns or awareness initiatives which needs further infiltration into the larger community. We do have policies and regulations like that.
There is
But
another
there
question.
are oral aspects.
My name is Saumiti. Can I ask a question, please?
Please go ahead. Please go ahead.
Yes, ma'am. You mentioned that the socio-economic strata of society is very important for determining the oral health of people. This being the condition, many of the issues with oral health are considered not as health treatment or as essential treatments, but many of them are considered as aesthetics, aesthetically improving one's appearance or condition. So in such cases, there is no medical reimbursement for such treatments. And as you rightly mentioned, oral treatment is formidably high priced. So
Yeah.
how are we going to resolve this?
Yeah. This is a very important question and a very important aspect, which is a challenge for oral health community of any society, for that matter, not just India. So, keeping this issue at hand, in 2015 and 16, we did a community case study. Where myself and the other two researchers, Dr. Chandrasekhar Janakiraman and Dr. Rajiv, we took a human rights approach to oral health, accessing oral health services. So, a human rights approach basically considers that every individual has a right to oral health as well. But right to health, so in our Indian constitution, if you look at, there is no direct explicit mention of health as a basic human right. We only go to court or seek justice or any of these through Article 21A, which says right to life. So if we have to achieve life, then health is important. So indirectly, we are trying to access through that Article 21. So we actually, in the Constitution itself, health is not mentioned as a fundamental human right. So oral health becomes even more neglected. As you said, the mainstream general population thinks that oral health is just for aesthetics, especially true maybe among higher socioeconomic strata, they may look at it like that. But it causes real pain and suffering when we have tooth decay or when we have severe periodontal disease causing abscesses inside the oral cavity, or when we have infections which need urgent emergency drainages, it is a real condition which causes pain and suffering. So it is not just an aesthetic component. So the human rights approach is very important, and especially so true, as you mentioned, for underprivileged sections of the society. So when we did that case study, we approached the community health centers. The dentists are appointed in community health centers. So we approached the government sector, we approached the government dental college and hospitals and private hospitals, and saw how patients are seeking and are able to access and afford oral health services. So what were the limitations? What were the hurdles? Could they really continue and complete their treatment? Many of them discontinued. What are the reasons for it? So all this was done so that we could present the case in front of National Human Rights Commission, because during that time, the National Human Rights Commission called for issues in accessing inequalities in the acquiring health, and even we wanted to represent oral health there, that people are not having it as a right. So it includes a lot of policy intervention. It needs policy level interventions, basically, because once we have a policy, it becomes easy for implementing programs and even having funding for such programs. As of now, we do not yet have the last year, in the month of March and April 2021, the Ministry of Health and Family Welfare has given a draft National Oral Health Policy, and it is there for public view. It called for public opinions, and it has closed now. But we are yet to wait for a final policy to come. So, and we do not even also have a national oral health survey data after 2014. As far as my knowledge goes, the latest what we have is 2014 data. So when we do not have data, we cannot have evidence-based policy as well. So there are a lot of hurdles and gaps to address this issue of what you have raised. If we have to achieve oral health across all socioeconomic strata, then we need a very good policy and for that policy, it should have an approach like a human rights approach. Only then I think we can shift the focus from only curative approach, as you said, from curative approach to a preventive and promotive approach.
Thank you, ma'am. I hope we do get some policies in place.
Yeah.
Thank you very much, ma'am. Last question. This is regarding role of dental hygienist. Dental hygienist, how it can improve the education, thereby improving the quality of oral health.
It's a very good.
And another question, madam. Sorry, another question alluding to it about how can we force the government to ban smoking or chewing gutka or anything else? I think they both are interlinked. So you can answer both of them. With that, we will end all the questions.
Okay.
Thank you.
Regarding dental hygienists, Dr. Nagesh sir also will guide me if I'm going wrong, sir. But as far as I know now, dental hygiene courses in India, they were used to be given, but now we don't see the courses for dental hygiene, and we don't have. We do see in our college, in my college, for example, we used to have dental hygienists. They all just recently retired. Now we don't have any more dental hygienists in our college. But if we have hygienists, they are called dental auxiliaries. There are many dental auxiliaries which can assist the dentist in delivering the service. It saves a lot of time, and it will make the dentist reach large number of people with quality dental care. It's a very good initiative if we can use dental hygienist for all the other roles, such as you said, giving oral health education or doing smaller scaling and cleaning purposes, services. But we don't have them practicing independently in India. That is about dental hygienists. About tobacco, it's a great problem across all countries. Actually, no, the powerful tobacco, the industry, the level of reach the tobacco industry has is unsurpassed, and the amount of funding it provides and the revenue the government generates because of the tobacco industry, we haven't seen any societies banning them altogether, but we do have policies and regulations which are in place, which the you must have you must remember that public smoking was banned during 2008 and 12. During that time, the policy also came, and public smoking is not there now as we used to see before. And the regulations like slowly shifting the cultivation of tobacco, the farmers who are dependent on tobacco cultivation, slowly shifting them to other forms of crops. All that is there in policies and policies. But the powerful tobacco industry is actually very, very powerful in terms of money and the reach. So we do not, it's an idealistic goal. Hopefully, more and more of research and policy interventions will lead to that way.
Professor Sushi, in continuation of your tobacco, I think we
Yes.
have done a 7.5 years work on that one. It was 2001. Karnataka state was the first state to ban tobacco smoke. Our 7.5 years work has given various all sorts of it. And I was involved in the Vidhan Sabha, making rules and revision, everything like that. Century Club is the first social club in India where tobacco smoking was banned in 1997. 97. And 2 years later, 2003, WHO, Government of India, Supreme Court banned tobacco smoking in India. These are all the data, and these are studies have shown definitely it has come down about 5% all over the world. All over the world. However, the girls smoking has becoming more. They think what way we are inferior. I think office going computer the officer they start smoking and all. The girls has increased 7%. Overall, it has 5% less. Girls has increased. We have to focus on these real issues.
And smoking tobacco during pregnancy especially leads to low term birth.
We have enough data to substantiate during
Yeah.
pregnancy and other things. But chewing tobacco, everything is banned. In continuation of that one, I just want to add it to this one. I think because of the time, we may not able to extend further. I request our secretary give the vote of thanks. Any question, probably we will direct them.
But we have all the products available in the market, even after banning. We have in different names. People are accessible to all these.
We have an organization, Doctors for Tobacco Ban. We have an organization in Delhi. We are all the member of that one, and we are propagating it. Even hookah has come. That one, hookah has come, and that is metallic thing has come. We are banning that.
E-cigarettes have been banned totally. Recently, it was banned.
So there is another last question. Our national coordinator and chief advisor, J.O.G. Rao, and past president of ComHead of India, is going to ask another question.
So many times I am a pediatrician. Many times I am facing, and the parents comes and ask me around 6 to 8 months or something, or 9 months or 10 months. So it is excessively crying and irritable. Could it be because of this eruption of the teeth? This is the question they are posing. Sometimes it's very difficult to answer, and sometimes somehow I could able to convince, but not scientifically. Probably it could be maybe, or maybe other reasons. But what's your opinion about this matter?
Sir, your voice is echoing, so I'm not able to.
I think his question is.
No, 1 minute. Because when I see the oral cavity, there are no inflammatory signs. Sometimes it is difficult to scientifically prove that because of eruption.
Sir, Parmesh, sir, can you repeat? Because
I think his question is, when the children are coming to the outpatient, some children are continuously crying, irritable, restless, and some of the grandparents says in our culture, "Ayo, hal karta ide, magu hal barta ide." So that's what the statement doing that, because 9 to 10 months first tooth coming, hal barta ide adke haltan bidu anತಾರೆ. Is it a fact? Because I cannot see any oral problem like that.
When the tooth is erupting, we call this eruption gingivitis.
Yes.
when the tooth is erupting, it causes slight inflammation in the gingiva because it has to pierce through the gingiva and come. So it is called eruption gingivitis, inflammation in the gums. Eruption gingivitis. So it will cause irritation and itching like thing. It will cause irritation to them. Mainly irritation, and some people might feel painful. So they may show that discomfort when teeth are erupting. It is true.
Maybe some research work has to be done in this context. It's a good topic.
Now, what is the line of treatment then? Whether could it be used something like any creams? Yeah, some people are using this.
How do we solve this problem? Are we going to prescribe some cream for the irritation, or can we have something chewing something hard thing for that one? What would you advise?
No, I do not. Personally, I do not advise them to chew anything on it because it's already inflamed.
Fine. Okay.
So it is just you have to make the child realize what is happening with its mouth. So if you explain the child.
No, it's a 3 month. There's a 10-month-old child. He cannot explain.
10-month-old. Yeah, no, for the especially when the permanent tooth erupts, right?
Yes.
That time they feel a lot of irritation more because they for very young children, for milk teeth they may not find it much. So yeah, I mean, I don't know if something is recommended. Oral medicine people, do they recommend any medications for it? I'm not sure about it.
Okay. I think it's been a very wonderful session today. One of the best sessions we can remember recently in our monthly webinar. We take this opportunity to thank Dr. Socio-Economic, Dr. Nagesh, Dr. Jayajirao, Dr. Parmesh for organizing the event, and all the delegates who attended the webinar today. Thank you very much, madam. I'm sorry that we could not take more questions. It seems there are more and more inquiries. So what I can request all the attendees is to direct the questions to us by email or message. We will forward it to Dr. Shobha.
Okay, sure. Thank you. Thank you very much. Thank you, Dr. Parmesh sir, and thank you especially to Dr. Nagesh sir. I learned a lot from what you explained after my talk, and it is a great privilege for me to present in front of Parmesh sir and Nagesh sir. Thank you so much.